So we have already started looking at antiviral agents, of course, for both the kawaida viruses and even the retroviruses, including the one for HIV and AIDS. And we have started with we did classify them. We did say we have DNA, we have RNA, and we had started with the DNA viruses. And we looked at some of the drugs like acyclovir, but we didn't mention the metabolism of acyclovir. So I want just to add that to what we had done last time. As we start, we look at them. We had looked at acyclovir, and of course we had looked at its mode of action, and we did mention that it lacks a portion of the ribose sugar. It has to be forced. There is selective toxicity in that. It can only be monophosphorylated in the virally infected cells, and then of course the other kinases, the cellular kinases, then will be phosphorylated to the triphosphate, which then will bring about the mode of action. So we did mention that we can still say it's a prodrug which is activated through phosphorylation and which has what we did mention, selective toxicity. So the only thing I realized we didn't mention is its metabolism, which I thought is important. Very, very simple metabolism. As you can remember, it will have a CH2O, CH2, CH2OH. That was the structure of the ACV. So in the body, it is metabolized into the carboxylic acid. So metabolism of ACV or acyclovir, and it is metabolized into the 9-carboxymethoxymethyl guanine. 9, of course, is position number 9, carboxy, that one, methoxymethyl guanine, and this is the primary metabolite of acyclovir and its prodrug valacyclovir. It is suggested that it is a causative agent of quite a number of CNS effects, like the neuropsychiatric side effects sometimes associated with these medicines, both acyclovir and valacyclovir. These are mainly suffered by patients with kidney failure or otherwise decreased kidney function. In other words, if you have a patient who has compromised kidney function, you would want not to give them either acyclovir or valacyclovir. Remember, valacyclovir was the prodrug of acyclovir for purposes of increasing bioavailability. So some of those effects include disorders, psychotic reactions. The person can have psychotic reactions. They can have hallucinations, and rarely a more complex disorder such as quarter delusion. And in this quarter delusion, it must be a very bad delusion. You feel like you are walking cop. So it's known as the walking cop syndrome. So what the person feels like they are dead. So they feel like they are dead, but they are walking cop syndrome. So there is that delusion of that feeling like you are dead, or they even feel like their internal organs, their intestines, internal organs are putrefying or are decaying or rotting. So you can imagine that's a terrible delusion where you are alive and like you are not alive. You have that imagination that you are a corpse and that you don't have your internal organs, you don't have your intestines, and even if they are there, they are rotten or decayed. So that it is one of the toxicities that one has to be careful about when they're giving either acyclovir and valacyclovir, especially for patients who have kidney compromise. So that is important for us to note. And as we have said, of course, this will be catalyzed by alcohol dehydrogenase or aldehyde. The final one will be aldehyde dehydrogenase to give us a carboxylic acid. So that was just to add to that. Let's see whether there is anything else I've added. I think this we mentioned, perhaps I didn't put it in a slide, but we can note that the DNA viruses constitute a heterogeneous group whose genome is composed, of course, of DNA. These are the DNA viruses, which we did give examples. They replicate in the nucleus of a host cell, so they are able to penetrate up to the nucleus. Some of the DNA viruses are simple structures, and they consist only of a single DNA strand and a few enzymes that are surrounded either by a capsule, and we have an example of parvovirus, all are surrounded by a lipoprotein envelope, such as hepatitis B. So we are saying that when we talk about the DNA, they can be either complex or they can be just a single strand, complex or a single strand, as we had discussed earlier. Other viruses, such as the herpes virus and poxvirus, all these are DNA viruses, are large, complex structures with a double-stranded DNA genome and several enzymes encased in a capsule and surrounded by an envelope. Remember what we call the lipoprotein envelope, consisting of several membranes. So you do have some of them which are very simple, only having a simple membrane surrounding them. Others are quite complex, are double helix, some are single helix, and of course, the complexity, when the virus is complex, then of course it makes the management or treatment of that condition a little bit difficult, because of course it can make it a little bit difficult. But we did understand that for most of these viruses, the advantage is that most of them, when they get into the cell, they will uncoat. So even if it has some of these coatings, then when it gets into the cell, it should be able to uncoat and release its DNA free in the cytoplasm of the host cell, and therefore that way it can still be acted on by the drugs. But what we are saying, of course, we have complex ones and some which are not very complex. DNA viruses contain DNA-dependent RNA polymerases. The ones which are DNA-dependent RNA, these are the normal transcriptases, and they also have the DNA polymerase, which of course we did mention that you do have these drugs that we have talked about. They are cyclovars, valacyclovars, which would inhibit the DNA polymerase. Various other enzymes, depending on the complexity of the virus, or the enzyme provide targets for antiviral drugs. So depending on the complexity of this virus, it can have other enzymes which it will require to help it, let's say, uncoat for the purposes of reproduction. Because remember, this virus can only reproduce in the host cell. And for it to reproduce, it must penetrate. Therefore, it must have enzymes to help it penetrate. It must uncoat. So, and therefore, to require various enzymes which can help it to uncoat. And because most of these enzymes are specific for the virus, they can also act as targets for drugs. And we'll be looking quite a number of them. We have mentioned some of these drugs, hydroxyuridine. All this are, of course, the ones we mentioned as antivirals. As a how do they work? As the monophosphates, they interfere with the biosynthesis of the precursor nucleotides required for the DNA. Remember, although they have structural similarities to the nucleotides, of course, they have differences, and because of those differences, once incorporated and put within the DNA, there will be the termination of growth of the DNA, or they will inhibit the enzyme. So as triphosphates, they competitively inhibit the DNA polymerase. The triphosphates are also incorporated into the growing DNA itself, resulting in DNA that is brittle and, of course, ineffective. It is defective, it is fraudulent, and therefore will not be able to do what it's supposed to do. The acyclonucleosides, and this of course include the AZV, such as acycloguanosine, are bioactivated sequentially by viral and host kinases. This we did mention. And of course, once they are the triphosphate, again, the same thing will happen. They will be incorporated and they will bring about activity. There is no 3-hydroxyl group available for the subsequent formation of the 3,5 phosphodiester bond with the next nucleotide, and therefore there will be DNA terminators, synthesis terminators. The structure of cyclovar, the cyclosugar chain rotated into a pentose configuration, shows clearly the absence of a 3-hydroxyl group. That indeed we had mentioned in details. So those are some of the examples. I believe we also started, those are some of the examples of, we started also on the reverse transcriptase inhibitors. I think we discussed quite a number of them. We discussed sidovudine. I think it's mainly sidovudine we discussed. So let's look at whether there is also anything. So we can also added something about the retroviruses, and we can note that they constitute a special class. Of course, the retroviruses, as found in HIV and AIDS, they constitute a special class of RNA virus that possess an RNA-dependent DNA polymerase, and this is what we call as the reverse transcriptase enzyme, and it is indeed required for viral replication. In these viruses, of course, remember, these ones are usually not they don't go directly into the nucleus, they are within the cytoplasm of the host cells. And in these viruses, a single strand of complementary DNA, which we call complementary DNA, is synthesized on the RNA genome that is reverse transcriptase, duplicated, and circularized to a double strand proviral DNA. All we are saying is that within the cytoplasm, they will make what we call as complementary DNA. And the complementary DNA will be first made as a single strand, and then it will be designed into a double strand DNA, or what we're calling the proviral DNA. And that is what we're calling in the complementary DNA. And that complementary DNA is then the one now that will move. It will combine with the integrase enzyme, and move into the nucleus of the virus, of the host. The proviral DNA is then integrated into the host cell chromosome DNA to form the template or apovirus or viral gene required for the synthesis of the messenger RNAs and replication of the viral RNA genome. As we are going to see later, more often than not, it also combines with the integrase enzyme. Two of its nucleotides are cleaved off from that complementary DNA. Then it moves into the host nucleus. It is integrated using the integrase enzyme, integrated into the host DNA, and now that works as a template. All the RNA from the virus is cleaved off, and that now complementary DNA integrated into the host DNA. Now it serves to synthesize the viral DNA, serves to synthesize functional proteins, structural proteins, and then, of course, the nucleic acid plus the functional proteins plus the structural proteins then come together to give you the virus. And then, of course, it through a certain mechanism, it leaves the host and moves out, causes and infects other cells, and the process is repeated again. So during the process of the complementary DNA biosynthesis, ribonuclease RNAs degrades the RNA strand, leaving only DNA. Remember, we started with the virus RNA, and using the RNA-dependent DNA reverse transcriptase enzyme, you synthesize the DNA, the complementary DNA, but sometimes it is still joined with the RNA. So there is this enzyme that cleaves off the RNA to leave you only with the viral. Remember, this is a viral DNA. The retroviral reverse transcriptase is a good target for chemotherapy, being inhibited by the triphosphates of certain nucleosides, such as, and these, of course, are the ones we have looked at. And if you looked at zidovudine at position number 3, it has an azido group. So that's why we are calling it a dideoxy, because also at position number 2 doesn't have anything. Then if you look at all the others that we looked at, be it the stavudine, the saucitabine, all of them are lacking in the position 2 and position 3 hydroxyl group. And because of that lack, especially for the position 3, there cannot be continuity. And once you give that drug, it binds these enzymes, this reverse transcriptase enzyme. It cannot be able to use it. The reverse transcriptase cannot be able to use these nucleotides for further development, growth, or further growth, either of the nucleic acids or of the functional proteins or the structural proteins. So the synthesis is terminated. Or again, as we had said earlier, they are incorporated within the growing RNA. And when they are incorporated in the growing RNA, then again, there will be termination, there will be development of RNAs of the wrong size. And once you get RNAs of the wrong size, they will be fraudulent, and the virus will not be able to further grow or even get more, which can infect other cells, and therefore you will halt its progress. And of course, we had mentioned quite a number of drugs, as we have said, zidovudine, lamivudine, stavudine, and emtricitabine. And when you look at them, you can see these 4 are pyrimidine derivatives. And of course, you have didanosine, abacavir, tenofovir, which indeed and purine derivatives. Of course, again, when you look at tenofovir, it is usually derivatized into its salt, into its, these are the organic salts for, I believe, for better bioavailability. So you can have, that is our tenofovir there. You can see these are tenofovir where it ends with a phosphate. So you can see the tenofovir ends with a phosphate, but you can have also tenofovir disoproxyl fumarate. So you can see the tenofovir is ending there. And then you have this as the isopropyl, and this is a fumarate here. And because they are two, so isopropyl fumarate, and because they are two, we are calling it diisopropyl fumarate. Or you can also have tenofovir alafenamide. Alafenamide, again, you can see our tenofovir adds there. So it's just the way we have been saying, sometimes you do derivatize these drugs into certain salts, either to like this, to increase, either to improve on their pharmacokinetics, to improve on their absorption, and therefore to have higher concentrations and therefore better activity. I think this we had discussed. This we had also discussed. I wanted just what I have added that we have discussed, that we have discussed. I think we had gotten here, if I'm not wrong. The clinical is used, of course, in AIDS and AIDS-related complex to control opportunistic infections by raising absolute CD4 lymphotic side effects. The most common adverse effect of sidovudine is myelosuppression, resulting in anemia. I think even this we discussed. GIT intolerance, headaches, insomnia, your burden to resolve during therapy. So, of course, these drugs will also have their own side effects. You also have stavudine. But I believe at the moment, of course, you have done these drugs in clinical pharmacy, you have done them in pharmacology. So you definitely know the drugs, that the formulations or the regimens that we are currently using. I think that's what we'll conclude with. I don't think we're using a lot of stavudine. I don't think the formulations in Kenya now have stavudine, but we can still note that it's a pyrimidine nucleoside analog that has significant activity against HIV-1 after intracellular gain conversion of the drug to stavudine triphosphate. The same mechanism of action throughout. First of all, they must be activated within the virally infected cells to give you the triphosphates that indeed will be taken up and will be the ones that bring about the inhibition. Another drug, and the emtricitabine, is important for us to mention, because when I was looking at the current formulations, you do find quite a number of them do have emtricitabine. And as you can see again, this is a pyrimidine derivative. That is a pyrimidine derivative. Indeed, this is cytosine. So it's a cytosine derivative, and it is an orally active nucleoside reverse transferase inhibitor whose pharmacokinetics are favorable for one's daily administration. That is quite favorable. And indeed, you will find it in quite a number of the ARV combinations. It is renally metabolized by a combination of glomerular filtration and active tubular secretion, and excreted. Approximately 86% is recovered in urine and 13% as metabolites. Most probably can be metabolized through deamination, as we had seen earlier with the anti-cancer drugs. Another drug is the tenofovir, again a drug which you find in quite a number of the combinations that are currently in use. But of course, tenofovir is a purine derivative. Tenofovir is a purine derivative. As you can see, that is its structure. Therefore, it's an adenine derivative. And again, it is derivatized into its salt, used to treat chronic hepatitis B also, and to prevent and treat HIV/AIDS. So you can be able to use it for prophylaxis because of prevention and also in treatment. But as you already know, about the heart, of course, you normally have in combination, and of course, the advantages. It is generally recommended for use, again, with other antiretrovirals. It may be used for prevention of HIV and AIDS among those at high risk before exposure and after needle pricks, injury, or other potential exposure. So it can be used prophylaxis. It can be used after exposure. It can be used also also for treatment. So it has quite a lot of use, and that's why I thought it was good for us to mention it. They sold both, of course, by itself and also and together in combinations such as emtricitabine and tenofovir. So again, I think this combination is readily available. You can also have it, of course, as evavirenz, emtricitabine and tenofovir. Going to look at evavirenz. It is a non-nucleoside reverse transcription inhibitor, and you can see you can't be able to combine these three drugs. You can also use elvitegravir. Elvitegravir is an integrase inhibitor. You can also combine it with cobicistat, emtricitabine, and tenofovir. We are going to look at that, what it is. It does not cure, of course, HIV/AIDS or hepatitis B, but of course, it will lower the CD4 count, it will lower the load of the disease, and of course give somebody quality life. It is available by mouth as a tablet or as powder. You can see this is the tenofovir. I think we look at it. So before we look at the metabolism, let us see what cobicistat is. Cobicistat is a component of 3,4 drug fixed dose combinations HIV treatments. So it is a pharmacokinetic enhancer or booster, which increases the overall absorption of several HIV medicines. So in itself, it is not one of the non-nucleotide or nucleotide reverse transcriptase inhibitor. It is a booster. It is a pharmacokinetic booster, and therefore, once you give it with these other drugs, you give a pharmacokinetic booster, then you enhance the absorption of those drugs. You delay their metabolism, and therefore, they will reach high concentrations much faster, and therefore, the drugs will be more effective. So it's a component. It is just put as a component of the HIV combination therapy treatment. So you can have, as we have said, elvitegravir, cobicistat, emtricitabine, tenofovir, and so on. So you can see again, and the tenofovir, you can either give it as disoproxil or alafenamide. You can give either of them, or you can give them also as cobicistat, darunavir, emtricitabine, and tenofovir, and so on. So we are saying it is an enhancer, which reduces, which helps you to give the other drugs in lower doses, in lower strengths. And once you give them in lower doses or lower strengths, then you minimize the toxicity. It is also a potent and selective inhibitor of cytochrome P453A, and most of these drugs are metabolites. They are substrate of cytochrome 3A4, and because they are substrate of cytochrome 3A4, once you give them together with the cobicistat, it will help to decrease their metabolism, and therefore act as a booster. Even when we look at the PIs, we will also see the tenofovir as the same action of acting as a booster. This is a tenofovir alafenamide. This is just its metabolism. So you can see, as we said, it is a prodrug. It has been derivatized into the alafenamide, and of course, our tenofovir adds there. So you have the enzyme, catalase enzyme, and the catalase enzyme you cleave at this point to cleave the phosphate from the amino group, and of course, you can see. Sorry, it's cleaving. The catalase is cleaving. Sorry, it's cleaving at this point. Sorry, it's cleaving at the ester. Sorry, the catalase is cleaving at the ester there. Sorry about that. So it's cleaving at the ester. So it is removing the isopropoxy group, and now it's giving us the tenofovir alanine. It's giving us tenofovir alanine because our tenofovir is up to there, and that is alanine. So it's giving us tenofovir alanine, and then after that you get acid hydrolysis in the lysosomes, and that acid hydrolysis now will cleave up to there to give us now the drug, which is the tenofovir. And then the tenofovir now, already you can see tenofovir has an advantage of already it has one phosphate. Then it undergoes adenylate adenylated kinase, because you can see this is adenine, adenylated kinase to give us the tenofovir monophosphate. We are calling it monophosphate, although it has two phosphate, because one of the phosphate is part of the structure of the tenofovir. So we are calling it tenofovir monophosphate, and then that goes nucleotide nucleotide diphosphate kinase, nucleotide diphosphokinase. So that is now already having, has actually two phosphates, so it is being again phosphorylated. So there is sequential phosphorylation, again undergoes further phosphorylation, catalyzed again by the diphosphoKinases, and now you have the three, although you have just added two, and now you have tenofovir diphosphate, because of course monophosphate, it came with its own, so that's tenofovir diphosphate, and that tenofovir diphosphate, this has now been activated. It is the one which you block the reverse transcriptase enzyme, and also block or bring about termination of the growth of the nucleic acids. Again, I believe in most of the formulations we do have quite a number of them that have tenofovir. As you can see, we have mentioned quite a number of them. And tenofovir, I think even now in Kenya, is being used also as one of the nucleoside reverse transcriptase inhibitors. Again, another important one is abacavir. If you look at abacavir, you can see again it's adenine, but adenine that has been methylated, not methylated, but it has been alkylated with a cyclopropyl group. Otherwise, I think because it has that, and of course also it has this amino group, which is there, not normally there in adenine. So we can say it is an alkylated amino adenine. So it's just a bit different. And then of course you can see at that position number 9, it has this group there, and that group resembles the ribose sugar, but of course is also different in that when you look at it, there is, so that is, you look at that's position 1, position 2, position 3, there is this double bond, and therefore it is 2,3 dideoxy. We do not have a hydroxy group at position 2 prime. And of course, we do require there not to be a hydroxyl group at that position, because we are using it to synthesize DNA. So for you to synthesize DNA, remember, you do not have the hydroxyl group at position 2 prime. You do not have a hydroxyl group at position 3 prime, so that it becomes a terminator, so that it inhibits the enzyme, because it does not have a hydroxyl group. Because remember, this is a position where the position 5 hydroxyl group of the next nucleoside or nucleotide will bind. So the 5th position, the hydroxyl group of 5th position, usually comes and binds on the 3 prime. The 5 prime joins on the 3 prime. Now you do not have a 3 prime hydroxyl group, so there is termination of, again, the growth of the nucleic acids, and hence, of course, you result in fraudulent DNAs, and hence the virus will not continue in its development. Again, it is a nucleoside reverse transcriptase inhibitor that has been approved, again, in combination therapy. In the tissues, it is metabolized step by step through phosphorylation to the monophosphate, diphosphate, and triphosphate. Abacavir is highly bioavailable and is effective by the oral route. It penetrates the blood-brain barrier efficiently, has been reported to produce life-threatening hypersensitivity reactions in some patients. Again, we do have quite a number of combinations in the abacavir, and I think even combinations that are also used for children. It is primarily metabolized via 2 pathways, whereby you have uridine diphosphate glucuronide transferase, and also alcohol dehydrogenase, and the result is to get inactive glucuronide metabolites and inactive carboxylate. So there you have our drug. And you have uridine glucuronide transferase, and of course, uridine glucuronide transferase just transfers the glucuronide. So you've got the glucuronide moiety or glucuronic acid, so you can see there's already this free hydroxyl group, so that free hydroxyl group undergoes glucuronic conjugation. The minute it undergoes glucuronic conjugation, the molecule is highly water soluble, just leaves, and it gives us a Bakava 5' glucuronide. Can also undergo so that, of course, adenosine can also undergo phosphorylation. You can see this. You can have adenosine phosphotransferase, adenosine phosphotransferase, and if you have adenosine phosphotransferase, you get a Bakava monophosphate. You get a Bakava monophosphate, and then you can have cytosine deaminase. And once you get cytosine deaminase, as we had said earlier, to cleave the whole of this group, cytosine deaminase, you cleave the whole of that group, and it will give us to give us so it has cleaved the whole of that group, and now this is now, look at this group now. It has a double bond here, and I mean that is now guanine, I believe. Cytosine, so it's this cytosine. This short form is monophosphate. See, because this now is like guanosine. I'll check what that stands for. And these short forms, that difficult to know what they stand for. So all we are saying is therefore the resultant group, the Bakava monophosphate, has now been phosphorylated. So it has been phosphorylated, and of course it still has its double bond there. It has been phosphorylated. It has also been undergone deamination, and of course, as far as I'm concerned, when you have a double bond there and an amino group there, which compound? Because when you have guanine has double bond there and double bond there. When you have adenine, it has an amino group there. So this, I think, is a different molecule. So it is of course still a purine derivative, but I'll check which name we give it. So what is important is, of course, for us to understand it has undergone deamination, and of course it is still phosphorylated, and this molecule now can still go through this. I believe this molecule can still have activity. It can still undergo diphosphorylation, diphosphorylation, triphosphorylation to give us a molecule that is still active. Then the other one is where we have this group here using cytosolic alcohol dehydrogenase, whereby again this group here now undergoes oxidation to give us a Bakava 5' carboxylase. That again, most of the metabolism of these compounds is simple metabolism, but still very, very important metabolism, because that metabolism will of course be what is responsible first for activation of these drugs to the active compound through phosphorylation, and of course also sometimes the phosphate, sometimes you get glucuronic conjugation, and once you get a glucuronic conjugation, then you will have the drug very highly water soluble and removed from the body. Any question out there? Then from there, we have the non-nucleotide reverse transcriptase inhibitors. Even this ones we had mentioned, at least we had started with nevirapine. As I said, when I was looking at the current drugs, I saw there were some compound that we hadn't mentioned. And that's why I have looked at them, because I also noticed that we do have them in the market. So these ones we had looked at nevirapine, I remember we had gone up metabolism of nevirapine. We can mention its pharmacokinetics. It is well absorbed by the oral route and is widely distributed throughout the body. We know, of course, nevirapine is used for mother-to-child transmission, distributes well in breast milk and crosses the placenta. It's extensively transformed by cytochrome again, cytochrome P4, 50, and that's most of these drugs are actually metabolized by the mixed function oxidases to inactive hydroxylated metabolites. We had said that it may undergo enterohepatic recycling that will give the drug quite a long duration of activity. The half-life decreases in use because of auto induction, and auto induction is where you find a drug. Giving a certain drug expresses a certain enzyme, and that enzyme helps in the metabolism of that drug. So expression of an enzyme that is responsible for the metabolism of agent expressing it. So it does have auto-induction, and therefore it will bring about enzyme that will break down the drug itself, and therefore initially it has a long half-life, but the half-life will decrease on multiple dosing because of the auto-induction. The elimination occurs with the kidney with less than 3% of the parent compound excreted in urine. I remember we had looked at its metabolism. Dosage forms you can have it in 50 milligrams per ml because you require it as an oral suspension for children, and also a 200 milligram tablets, generally used again in combination with other drugs to avoid development of resistance for HIV. Highly active antiretroviral therapy. It is synergistic with other, like of course with the nucleotide reverse transcriptase inhibitors, and also the protease inhibitors. And of course, I believe it's still used for the mother-to-child transmission. Another one is delavadine. It must be used again with at least 2 additional, as we have said, it's becoming a song. It has a rapid oral absorption and quickly attains peak plasma concentration. Again, extensive metabolism through cytochrome 3A4 and cytochrome 2D6. These are the enzymes that are mainly metabolize these drugs, and that is why sometimes you can have issues because they are able, also some of them are able to induce these enzymes, and also if they induce the enzymes, that will mean they will also have an influence on the metabolism of other drugs and can bring about drug interaction. Has good bioavailability, highly protein bound, elimination in feces, in urine, and you can use oral dosage of 200 milligrams capsules and 100 milligram tablets. So again, that also is a nucleoside reverse transcriptase inhibitor. Then we have a very important one, a very commonly used one, evavirenz. Evavirenz. Don't think we had discussed evavirenz. Evavirenz is a non-nucleotide reverse transcriptase inhibitor, just like nevirapine. It is mandated for use with at least again 2 other antiviral agents, highly protein bound, and also attains very good CSF concentrations. Metabolism occurs in the liver, has a very long half-life, which decreases again on multiple doses due to induction of own metabolism, and peak concentration is achieved within 3 to 8 hours. And as we have said again, on multiple dosing, it has a very long half-life, but the half-life will decrease on multiple dosing. The half-life again will decrease because of the auto-induction, or the fact that it will induce its own metabolism through induction of enzymes. Elimination in urine as metabolites, and that the oral dosage form is applied as a capsule. Of course, these are also quite a very important drug, and non-nucleoside reverse transcriptase inhibitors. But one has to be very, very careful of the other. You see, one of the major problems of HIV and AIDS patients is some of the opportunistic infections. Like sometimes they have other drugs that they are taking. So you find that some of these drugs, because of the fact that they can induce other enzymes, one has to be careful which other drugs they are giving them with, because if you're not careful, then you can have combination, you can have interactions, you can have interactions, like if you're giving them with drugs with patients who are also taking rifampicin and such drugs, you will find that there will be a lot of drug interactions, because this will induce some of the enzymes that are gonna break down or are gonna metabolize the rifampicin, and indeed more often than not you can see if the evaluance has to be given, then it will be given with rifampicin and not rifampicin. So the combinations that you use in the various patients, the drugs, the regimen sometimes must be individualized. It must be individualized because it will depend on what other drugs that patient is taking. So it must, or even as you combine the various drugs, as we have said, you must be very careful to understand any other conditions or the comorbidities that the patient has, so that now when you give them the drugs, you do not give drugs that will have drug-drug interactions and, of course, have a lot of failure. Or you give drugs that can bring about a lot of toxicity. So chemical structure and metabolic pathways of metabolism of evavirenz, that is, it doesn't have a very complex structure. It is mainly metabolized to inactive 8-hydroxyevavirenz, 7-hydroxyevavirenz, and 8-14-dihydroxyevavirenz. Reactions again catalyzed by cytochrome 3A4, cytochrome 2A6, cytochrome 2B6. So most of these drugs, as we've already seen, are usually metabolized through oxidative, either aromatic oxidative hydroxylation, like you can see this one. You can have the 8-hydroxy metabolite. This is the 8-hydroxy metabolite, whereby, so if this is position number 8, where are we starting to count? Let's see, 1, 2, 3, 4, 5, 6, 7. We are starting here. Position 1, position 2, position 3, position 4, 5, 6, 7, 8. This is carrying number 1. So position 1, 2, 3, 4, 5, 6, 7, 8, and you get our 8-hydroxyevavirenz. So you can't just see, and of course that metabolism is being promoted by that amino group. You see, this amino group S also is it adds the electrons into the system through the resonance. So that's what's promoting that metabolism, because indeed you can see we do have a chloro group, but you still can have, it's like my Dylan. Do you hear me? I think my internet was off a bit. Can you hear me now? Can you hear me? I think it went off a bit. Last, can you hear me? Okay, Naomi, thank you. So I don't know whether it went off. All right, thank you. I think it had gone off on my side a bit. So the drug mainly metabolized through cytochrome P450 enzyme, and it's an enzyme inducer, and of course those issues are there. So that through cytochrome 2B6 and 3A4, 8-hydroxy, and then the 8-hydroxy can go on further metabolism. But even if you can't remember the actual enzyme, again, by the cytochrome P450 enzyme, specifically the 2B6, now to give us the 8 and 14. So you can see here is where we are getting our 14 on the cyclopropyl group, 8-14-hydroxyevavirenz, or it could have, this is the 8, or it could get the 7. So we are saying it can get 7, it can get 8, and it can get 8 and 14 dihydroxyvalase. And of course, once the addition of the hydroxy groups occurs, the compound is a little bit more polar, can get back into can be excreted, and of course there is termination of activity. We can note that these drugs inhibit the reverse transcriptase selectively. They do not inhibit, as we had said earlier, the reverse transcriptase of other retroviruses, including the HIV-2 and also simian immunodeficiency virus. So they are very specific for the HIV-1 reverse transcriptase, and therefore, once they are selective in that area, there is minimal toxicity. They have high therapeutic indexes, in contrast to the nucleoside, and do not inhibit DNA polymerases. So that is a good advantage. Their main problem is a rapid emergence of resistance among the HIV isolates. The resistance occurs as a point mutation in the gene coding for the enzyme. So the resistance is because of mutation, and cross-resistance between structural different non-nucleotide reverse transcriptase inhibitors is more common than between NNRTs and NRTIs. That's why you even will mix, you will combine NNRTIs and NRTs, because when you put two, there is even more cross-resistance. The NRTIs, examples, zidovudine, and the non-nucleotide reverse transcriptase inhibitors are expected to exhibit a synergistic effect on HIV because they interact with different mechanisms on the enzymes. Of course, one binds directly. Once you see the AZTs, we said what they have has to happen to them. They must be phosphorated and so on. And these other ones, I think we did mention that they bind an allosteric place and cause conformational change, and therefore distort the binding. Combination with the nucleosides reduce toxicity to the latter to take advantage of additive or synergistic effects and to reduce the emergency of viral resistance. So there is synergism. When you do synergism, there is, when you combine and there is synergism, use less doses, less toxicity, less emergence, less likelihood, reduce the emergence of viral resistance, but unfortunately, ultimately, it still develops.